Today we're going to look at ventricular rhythms. This is part of the cardiac electrophysiology lessons that we shall be looking at. And in this video, we shall break down the ventricular rhythms and how they appear on an electrocardiogram. The ventricles have an ability to generate their own electrical impulses that is independent of the nervous system control. So if ventricular beats are generated independently, they have some unique characteristics. The ventricular rhythms are characterized by a wide QRS complex. When electrical impulses do not travel in the usual path through the band of His and the Purkinje system, the depolarization of the ventricle cells is slower. This results to a widened QRS complex. Then we have what we call upper D T waves. The general direction of a QRS complex is opposite of that of the T wave in this time. Normally, the T waves follows the major direction of the QRS complex. And the last characteristic is that the P waves may be absent or they may be unrelated to the QRS complex. Let us start with the first rhythm, premature ventricular contraction. In this case, ventricular premature beating originates from the right ventricle. It may also arise from the left ventricle, and regardless of the origin, they'll be basically having similar characteristics morphology. And some characteristics of a premature ventricular contraction are there is a premature QRS complex. The premature beat is wide and bizarre in nature. It basically does not look like the other QRS complexes. Then as any other, and then just like any other ventricular rhythm, we will be having upper D T wave, which is a T wave that is opposite the direction of the majority of the QRS complex. And one characteristic feature is that has a compensatory pause. Basically means that there is a pause following the premature complex. Looking at the electrocardiogram image in this video, the pause is equal to 2 R to R intervals. And whenever it's just 2 times of the R interval, we call it a full compensatory pause. Premature ventricular contractions are by themselves not dangerous. However, when they occur in presence of a significant cardiac disease or electrolyte abnormalities, for example, hyperkalemia or hypokalemia or magnesium electrolyte disorders, they might pose a danger to the patient. The possibility of these PVCs to progress to a sustained ventricular rhythm or to a ventricular fibrillation is quite high. Frequently occurring premature ventricular contractions is an indication that the ventricles are becoming irritable. So how do we describe a premature ventricular contraction? We describe these type of rhythms either based on the morphology or based on the frequency of the occurrence. When we classify them based on the morphology or the shape, we have 2 types. That is a unifocal premature ventricular contraction and a multifocal premature ventricular contraction. When we say unifocal premature ventricular contraction, all the PVCs look alike and they most likely originate from the same foci. On the other side, a multifocal premature ventricular contraction is the one that has a varied shape and appearance, and this characteristic suggests that the origin is several foci or several areas of the ventricles. Again, when we classify premature ventricular contractions based on the frequency of occurrence, we can say we have a paired or couple, which means two premature ventricular contractions occurring one after another. If we have a PVC after every other beat, we call it bigemini. If it occurs after every third beat in an electrocardiogram, we call it trigemini. And after every fourth beat, it's easier, a quadrigemini. Then lastly, we have three premature ventricular contractions in a row. We call them triplet PVCs. So pause a video and try to look at these electrocardiograms that were attached here. One for a coupled PVC, which occurs in pairs. Then we have a bigeminal premature ventricular contraction, which occurs after every other beat. And lastly, we had a quadrigeminal PVC, which occurs every fourth beat. Another type of ventricular rhythm is known as idioventricular rhythm. From cardiac physiology, if you remember, the firing rate of a ventricle is between 20 to 40 beats per minute. In situations where the ventricles take over as the dominant pacemaker, this rate is the one that we observe on an electrocardiogram. Some refer this rhythm to as a slow ventricular tachycardia. However, try to think of it. Ventricular tachycardia and the word slow. The name itself is a misnomer because tachycardia means we expect to have a very fast heart rhythm, but in contrary, we have a slow heart rhythm. Therefore, the correct name for this one is idioventricular rhythm. Looking at the idioventricular rhythm, we have what we call accelerated idioventricular rhythm. When an idioventricular rhythm goes beyond 40 beats per minute, it means that it has exceeded the upper limit of the normal ventricular firing potential, which is 40 beats per minute. And in this case, the rhythm can be defined or identified as an accelerated idioventricular rhythm. However, for this condition, the upper limit is 100 beats per minute. If it becomes faster than 100 beats per minute, then it's referred to as ventricular tachycardia. So let's proceed to ventricular tachycardia. By definition, ventricular tachycardia is the presence of 3 or more premature ventricular contractions in a row. In this ECG that we have shown up here, the cardiac output is compromised and may result to a cardiac arrest. The ventricles here have a wide ventricular complexes with a rate of more than 120 beats per minute. This means that the ventricles are bombarded by numerous ectopic foci, which results in tachycardia. The characteristics of a ventricular tachycardia are: this rate will be fast and regular in rhythm. Then we'll be having a rate of between 140 beats per minute to 250 beats per minute or even faster. Looking at this scenario, we have a wide QRS complex, and then the P waves in this case are not associated with the QRS complex. And if the P waves are not associated with the QRS complexes, we don't expect to measure the PR interval. It is basically non-immeasurable. Ventricular tachycardia lasts less than 30 seconds or more than 30 seconds. If it lasts less than 30 seconds, we call it a non-sustained ventricular tachycardia. And on the other hand, if it lasts more than 30 seconds, we refer to it as a sustained ventricular tachycardia. Ventricular tachycardia is best described by indicating the number of VTachs that appear on an ECG or such. Looking at this electrocardiogram image that we have, we are basically seeing a ventricular tachycardia with 3 or more consecutive beats. The heart rate is less than 100 beats per minute, regular, and the P waves are not related, and in other cases they are absent. And the PR interval, like we mentioned, cannot be measured. What are the types of ventricular tachycardias that we're able to identify? We have 2 types of ventricular tachycardias. One is a monomorphic ventricular tachycardia, and the other one is what we call polymorphic ventricular tachycardia or Torsades de Pointes. Let us look at a monomorphic ventricular tachycardia. When the morphology or the shape of the ventricular tachycardia is the same in the same lead, we call it monomorphic ventricular tachycardia. In polymorphic ventricular tachycardias, the QRS complexes vary in direction and in polarity. Look at the image on the left column, where we have 2 ECGs, one for a monomorphic ventricular tachycardia, and below it we have a Torsades de Pointes or a polymorphic ventricular tachycardia. The edges or the points of the QRS complexes alternate in directions, so it looks like a Paris streamer. This form is associated with a long QT interval in a resting electrocardiogram. It is challenging to perform a cardioversion in this type of rhythm because of the twisting of the QRS complexes. Basically, this QRS complex is chaotic. What are the implications of ventricular tachycardias? A short run, ventricular tachycardia does not affect cardiac output, but if it's sustained, then it can affect the cardiac output. Normally, the treatment of ventricular tachycardia depends on whether the patient is either symptomatic or asymptomatic. Let us proceed to ventricular fibrillations. A ventricular fibrillation is a wavy, chaotic, and disorganized pattern of waveforms on an electrocardiogram. These waveforms can vary in shape, amplitude, and deflections. They basically can be defined as a quivering state of the ventricles. In this case, in our ventricular fibrillations, we do not expect to have an effective cardiac output. Sometimes the disorganized pattern will have a big amplitude waves and others will be small. The rhythm may be referred to as a coarse or fine ventricular fibrillation. Pause a moment and look at this electrocardiogram that we have on the left side. We have 2 images, one for the coarse ventricular fibrillation and one for the fine ventricular fibrillation. In coarse ventricular fibrillation, we have an amplitude of these ECG waves that is greater than 3 millimeters. On the other hand, a fine ventricular fibrillation could pose difficulty in differentiating it between VF and asystole because the amplitude is less than 3 millimeters. Ventricular fibrillations basically require emergency treatment with immediate defibrillation. And we defibrillate our patients using an automated external defibrillator and performance of effective cardiopulmonary resuscitation or CPR. And in the long term, we have therapies that include an implantable defibrillator and medications which can be able to prevent recurrence of this ventricular fibrillation. Lastly, we have one of the important cardiac rhythms known as ventricular standstill or asystole. Basically, asystole is an absence of systole, which means there's absent heart contractions. From the terminology that we use, an ECG will suggest a flat line or an absent ventricular activity, which results in a zero cardiac output. And in some instances, we could either be having an atrial activity, but ventricular activity is not present. So we call that one as ventricular standstill.